Our next panelist is Assistant Professor Jason Purnell. Dr. Purnell is trained both in applied psychology and in public health, and currently assists as Assistant Professor at Brown School and as a faculty scholar at the Institute of Health at WashU. His work focuses on socioeconomic and sociocultural aspects and their influence on preventive medicine. He works with diverse populations and engages in community efforts. So we look forward to how this impacts on healthcare disparities. Dr. Purnell.
Thank you. I have a couple of caveats. I kind of cheated on my presentation. I am not showing you Missouri data. I'm showing you national data. But I promise you that the ideas that I'll be presenting will be applied in Missouri. We are very fortunate to have funding from the Missouri Foundation for Health to be doing a study of African Americans in the St. Louis region. We'll be releasing some policy briefs that will lead up to a report that comes out next March, which will coincide with the 60th anniversary of Brown versus the Board of Education and the 50th anniversary of the Civil Rights Act of 1964. So stay tuned for that. I like to start with this slide, which was developed by Dr. Thomas Frieden of the Center for Disease Control, or the CDC. Yes, the Center for Disease Control and Prevention. I want you to direct your attention to the bottom of this pyramid, which is where Dr. Frieden suggests we're going to have the largest impact on community health. And it's not something that we've talked an awful lot about today. We've talked a lot about medical care and healthcare access, all of which are crucial and important. I don't mean to minimize that at all. But we know that only about 10% of what contributes to premature mortality has to do with medical care. And the rest has to do with people's behaviors and the social circumstances that they find themselves in. So this is where I spend a lot of my time thinking about how do we intervene on that bottom part of the pyramid, that part that talks about socioeconomic factors like poverty, education, housing, and inequality. And this is part of what we're dealing with when we talk about socioeconomic status. This is what we call the gradient in public health. And all this is saying is that as your income goes up, at each stage that your income goes up, your risk of dying prematurely goes down. And this is a fairly consistent finding across populations, across countries even, that we find in public health. We have to find a way to deal with this inequality. Now, the purpose of our meeting here today is to talk about some racial and ethnic disparities, but when you overlay socioeconomic status on some racial disparities, this is heart disease death rates among men and women by race and by family income. And what you see is that for both men and women, the largest disparities are by socioeconomic status. So if you look at those light gray bars, those are whites. You look at the black bars, those are African Americans. You'll see that the difference between the income groups are going up as you go to the right, are much larger than the relative difference within income group between whites and blacks. So we're dealing with something that's far more complex than just race or just socioeconomic status alone. You'll notice that even when blacks are at the same economic status, they do worse than whites. To introduce a little more complexity, this is our best thinking for how socioeconomic status impacts health, and then health impacts socioeconomic status. The economists spend a lot of time worrying about endogenous effects, which means how do you separate out what happens first, essentially. Well, this is suggesting that it's really hard to separate out what happens first. But what we know is that a child's socioeconomic status growing up in a household is going to be strongly predictive of their later health, even into adulthood, even if their socioeconomic status improves beyond that of their parents. And what this is showing in a fairly complex way is that health enters in and out of this equation, both predicting socioeconomic outcomes and being predicted by socioeconomic outcomes. So this is a complex set of relationships that we're dealing with. What I want to talk to you about is the difference between income and wealth. So we had some data this morning about income, and it's helpful data. We have very little data at the local level about wealth, and I want to talk to you about why that's important. Income is defined very simply as the flow of resources into a household. And what we know about income, as I said, income during childhood predicts adult health. Your parents' level of socioeconomic status is predictive of a child's health both in childhood and in adulthood. We know that short-term improvements in income aren't all that helpful in terms of improving the health of adults in particular. But long-term improvements, particularly among the poor, can improve health, and particularly among children. Wealth is a slightly different animal. Wealth is the total accumulated resources of a household. And a lot of people don't think about wealth in terms of its association with health. People think of wealth and they start thinking of Bill Gates or Rupert Murdoch and people like that. Only they have wealth. Well, no. Every household has wealth. If a household owns a car, it has an asset. Wealth is again, this total accumulated resources of a household that's consistently associated with mortality. I could show you that same graph I showed you for income, for wealth, with that gradient going down as wealth goes up. It's also generally associated with people's self-rated health, their functional status, how well they're doing with their adaptive activities of daily life, and chronic disease. And it's associated with cardiovascular risk factors. And we know that cardiovascular disease is the #1 killer of Americans and the #1 killer in the state of Missouri for most groups. Racial disparities in wealth are actually widening. Whites have about 6 times the wealth of African Americans, and that's bigger than it was 10 years ago. These are some graphs that show the disparity in wealth. And we can see from this, and we're not surprised to see from this, that the Great Recession, as we're calling it, has taken a hit on everybody's wealth. That's where you see at the far right end of this graph, all the lines are going down. Everyone lost wealth after 2008. But look at the gap between that top line, which is white households, and the bottom 2 lines. The light blue line is Hispanics, and the green line is non-Hispanic blacks. You'll see not only that the gap has gotten bigger, but also that wealth for blacks and Hispanics hasn't risen all that much. And this shows you that the Great Recession didn't treat every household equally. Hispanics lost the most wealth from the Great Recession. They lost about 44% of total net worth. They lost 49% of home equity, the value of their homes, and about 18% of retirement savings. African Americans also fared worse than whites across the board. Whites actually improved retirement income in this period that we're looking at. So why does this all matter? Because we believe, my colleagues and I believe, that there are health-related benefits of wealth in terms of having an economic cushion when you have a medical emergency or some other kind of emergency when you lose your job, but also in terms of having a greater likelihood of higher education. We know that education, I could show you that same graph I showed you for income for education levels. Education is actually more consistently and more tightly associated with health outcomes than even income is. But also these psychological, social and psychological impacts that wealth, we believe, provides for people. A sense of security, a sense of confidence about the future and the ability to even think about the future, a sense of control and personal efficacy over your own destiny, an increased risk aversion. If you have something to lose, you're less likely to engage in risky behaviors, and more goal-directed behavior. We believe all of these are what my colleague at the Brown School, Michael Sheridan, has called asset effects. These are in addition to the economic effects of wealth, what are the social and psychological effects of having wealth? So I said we, my colleagues, I lead a working group on asset building, financial capability, and health, which is co-sponsored by Michael Schroden's Center for Social Development at the Brown School and the Health Communication Research Laboratory. And this is a transdisciplinary academic community collaboration with WashU, UMSL, the Federal Reserve Bank, United Way, and Beyond Housing in St. Louis. We're really interested in how do you design interventions that use financial capability and asset building to move the needle on health disparities. And this is why we think it should work. We believe that when people accumulate assets, they have these asset effects that I was talking about. And we believe that those asset effects are pertinent for preventive health behaviors like smoking cessation, like diet and physical activity, and that those health behaviors will have an impact on health outcomes. And that all of this is happening within the context of their beliefs around both savings and around health behavior, and also happening within a larger social and cultural context. So, the national data I was talking about. The purpose of this study was to examine the association of changes in wealth. So what happens when people's net worth goes up or down, and the leading health behaviors and risk factors that are related to chronic disease and mortality in the United States. And the behaviors we were interested in were smoking, overweight and obesity, which is a risk factor, physical activity, and problem drinking. This data is from the 1999 to 2009 waves of a study called the Panel Study of Income Dynamics, which is the longest running longitudinal study in the world, I'm told. They've been collecting data on people since 1968. They're now collecting on the grandchildren of the original panel of this data. And what we looked at for wealth was net worth. So net worth is your total assets minus your total liabilities or debts. And we looked at 6 categories for this. People who had negative net worth, of which there's a substantial group, more substantial than one might think, and then quintiles or fifths of the rest of the distribution of net worth. And again, the health outcomes, this is how we define the health outcomes and risk factors, using longitudinal data analysis and controlling for important factors like age, education, income, race, and gender. So what we're reporting are the effects of these changes in wealth after you've adjusted for these other factors. This is a description of the sample. The nice thing about the PSID is that it oversamples for racial and ethnic minority groups. It oversamples for low-income groups. So this isn't a high SES, or in fact, there's not as much data on the highest end of the wealth distribution. And after adjusting for all of those relevant covariates, jumping a group. So I told you about those 6 groups. If you jumped one group in terms of your net worth between 1999 and 2009, you had decreased odds of current smoking, of obesity, of light physical inactivity, so being inactive physically, and of problem drinking for both men and women. But there were no significant associations with being overweight or with physical or heavy physical inactivity. So the basic conclusion, and these are preliminary findings, but the basic conclusion is that a change in household wealth has some influence on behavioral risk factors, even after accounting for the traditional measures of SES or socioeconomic status that we think of in terms of income and education, and these other demographic factors like race and gender. We still want to know, do health behaviors and risk factors predict changes in wealth? So remember, I told you that it's complex and it can move in both directions. So we need to know if the arrow points the other way. Maybe if you don't smoke, you're able to accumulate more wealth, for instance. Is there a wealth threshold where health effects begin? Is there a certain amount of money that you need in order to observe these health behavior changes? And are the wealth effects on health behaviors different by level of SES? And my guess is yes. A little bit of creation of wealth at the lowest end of the socioeconomic ladder is likely to be more powerful than if Bill Gates gets another $100 million, in addition to the $30 billion he's already got. This is a sketch of what we think might work in terms of one health behavior, which is smoking cessation. Along the bottom is what we currently do. We give people smoking cessation programs. We hope they quit. We hope they stop. It typically takes somebody 5 to 7 times to stop, and we have terribly low rates of uptake among particularly low SES populations. And Ryan talked this morning about the high rates of tobacco use we have in the state of Missouri. So this is a real challenge. What if we gave people an asset-based incentive along with the smoking cessation intervention? What if we helped them to save the money and even match the savings on their foregone purchases of cigarettes? We believe that asset accumulation would happen. You would see those asset effects in terms of increased self-efficacy, future orientation, and risk aversion, which would reinforce smoking cessation behavior. As people hold assets and invest in assets, we believe you see these longer-term asset effects that would decrease financial strain and psychological stress and allow people to weather economic crises and see, hopefully, long-term tobacco abstinence. This is the idea. We still need to test these ideas. So that's my other caveat. I don't have the results of doing this, but this is sort of a look towards the future in terms of what we may be able to do. I want to acknowledge my collaborators, the Center for Social Development, and the working group in this work. Thanks.